All right, good morning, everyone. Welcome to Surgery Grand Rounds. It's 7:31, we'll get started. For those of you that are online and here in person, the CME code is listed on the slide, 54949. So we'll get started here. It's my pleasure to introduce Dr. John Goss. He is honestly one of the leaders in abdominal transplant surgery in the United States and in the world. Over the last 25 years, he's built one of the largest adult and pediatric liver transplant programs in Texas, and honestly one of the largest pediatric abdominal transplant programs in the United States. He has done that, be able to leverage these exceptional clinical volumes and outcomes, and he's pioneered several different surgical techniques in performing the first in situ split liver transplant in Houston and establishing the first large split liver program in the country, in the area. He also performed the first adult living donor liver transplants in Houston. He is exceptional in terms of his academic productivity, with more than 375 peer-reviewed publications, an H-index of 80, an I-index of 236, and like 19,000 citations. Dr. Goss has held numerous leadership positions at Baylor St. Luke's Medical Center, Texas Children's Hospital, and Baylor College of Medicine, where he's been able to drive significant advancements in clinical productivity, quality, and operational efficiency. Through these combined clinical and academic administrative efforts, he's trained multiple abdominal transplant fellows and inspired generations of Baylor College of Medicine general surgery residents to pursue careers in abdominal transplant surgery, and including a son who wants to be a pediatric surgeon, making the best decision ever. In addition to these impressive career accomplishments, one of the coolest things I found is that Dr. Goss played level one, Division I baseball at Wyoming. He hit over 400 one of his last years and was drafted in the 37th round, which I think is pretty darn cool. Then he made the amazing career decision to become one of the best abdominal transplant surgeons in the world. So thank you that. And today we're honored. I'm very honored to welcome Dr. Goss here to present his Normothermic Machine Perfusion of pediatric donors, meeting unmet needs in pediatric liver transplantation. Thank you very much, Dr. Goss.
Great. Thank you for the very kind introduction, and I'm glad to be here. It's great to be able to present some of our data on basically something that I've tried to do for 30 years now, is figure out a way to make sure that everybody who needs a pediatric liver transplant gets one. And so over my career, we've used many different ways to try to get extra organs, living donors, split donors, technical variants, all kinds of other things. So I'll talk about what we're doing now, and I don't have any disclosures to acknowledge. So anyway, one of the things that we're going to talk about is, what was said is, we're going to talk about normothermic machine perfusion. And why would we do that? And the reason we would do that is right here, because the pediatric donor pool has not advanced at all in the past 15 to 20 years, basically. It's been flat. We have not been able to get additional donors. And so we have to figure out a way to come up with other organs for these pediatric patients. And the other thing is that in pediatric liver transplantation, we spend a lot of time talking about living donor. We all talk, and we don't do them. There are very few living donors done. As you can see from this line right here, it's been flat for the longest period of time. Oh shoot, that was the wrong one. But anyway, so we haven't made any progress on any of these ways. So the biggest problem with pediatric liver transplantation, and the reason we can't realize the full potential, is we don't have enough organs. So what kind of organs do we really need? Well, as you can see here, based upon these line graphs, the largest percentage of the kids that need to be transplanted are small children. They're not just adults that are younger. They're small children. As you can see from this line graph, most of the children are anywhere from 1 to 5 or less than 1. So we need grafts that we can transplant small kids with. And so we need to find more of them. And as you can see, this is the largest population right here. So then what has happened with deceased donors by age? And as you can see here, the blue line at the very bottom, blue-purple, if you look at the number of pediatric transplants that are less than, or the number of organs that are less than 18 years of age, again, that pool is flat. But if you look at the adult pool, especially with beginning of using different DCD techniques to use these donation after cardiac death allografts, that number has risen dramatically. And, you know, a couple of years ago, we were flat in the United States, and we were just talking about Michael Jordan, but Michael Jordan had an organ donation program for a while, didn't help anything. There were 6,000 to 8,000 livers done every year in the United States, and that was it. It was just flat for a long time. Well, now, since we've figured out how to use these DCD livers, it's well over 12,000 every year. It's the number of allografts has increased dramatically. So at our program, we're saying, why can't we do this for the kids? Because we don't want to see kids not get an allograft. And so we know that with the machine perfusion of DCDs, and I'll show you in a little while as well, fatty organs and things, you can transplant many more organs. So why can't we do that as at the bottom of the slide? Why can't we do this for a child? And the reason that's important is on this slide right here. If you look at adult transplants, oh, I keep doing that, I'm sorry. If you look at the adult transplants, I'm not so sure how to use this. Anyway, I can use the red dot. If you look at adult transplants, you can see that since about 2022, the number of DCD organs used has risen dramatically. And if you look at the total number of transplants that has increased, you can see it's really because of this population right here. Living donation, again, lots of talk, flat activity. And then you can see the DCD, which has taken off, and then DCD with machine perfusion. It's right here. This is where the difference has been made. Now, in that same period of time, if you look at children, none of that has happened. Okay. Pediatric transplantation is flat in the United States. Allografts have not increased. Living donation has not increased. We don't do DCD organs in children, and we haven't used DCD plus machine perfusion. So that's why we think we should try to move to using a machine to pump these livers to get more allografts for these children. And so what other supportive data do we have? Well, if you look between 2020 and 2025, only 3 DCD livers were used in pediatric liver transplantation based upon the OPTN database. However, there were over 1,200 pediatric donors that were attempted to be allocated less than 50 years of age. Now, you'll see in my talk, lots of times we'll talk about less than 35 kilos, and for sure less than 50, because we want to talk about children. We don't want to talk about small adults. That's not important. The children are what is important. So we're looking at over 1,200 DCD pediatric allografts that were attempted to be allocated and were unsuccessful. And then in the adult population, during that same period of time, there were almost 1,700 adult livers done, which at that point was 16% of the total adult volume. But as you'll see, that has risen dramatically. So there's a very large number of pediatric allografts that are not allocated. And why? Well, DCD, we're afraid of ischemic cholangiopathy in child, long travel times, long ischemia times. One of the things that we found is that extended and prolonged downtime in the resuscitation phase, these pediatric donors is probably not important at all. Elevated enzymes, improper size matches. There's all kinds of reasons why pediatric livers don't get used. So that's why we tried to figure out a way to get more organs, and pumping livers is one of the ways that we can do it. So why did we think it was worthwhile doing? And we've gotten a lot of questions about the ethics of doing this. Like, how can you all of a sudden decide to use DCD livers and things in children? Well, I'll tell you why. It's because if you look for ischemic cholangiopathy, we don't see that in children. It happens in adults who have, it happens in children who have hepatic artery thrombosis. Otherwise, you don't see it. Very uncommon to have ischemic cholangiopathy in a child. Many times when you're taking the donor offer, the pediatric donor has well over 30 minutes of downtime. The drowning victims, people worry about infections, and there's all kinds of reasons why we don't want to use a drowning donor. There's going to be high resistance in the donor, and all those things have been brought out. And so there's many reasons why those we've used and have turned out to be okay. So we got over the whole drowning donor fear. And then, as I said before, ischemic cholangiopathy only occurs in children that have hepatic artery thrombosis. And you can also see there's been a lot of teenagers used in adults, and the outcomes are great. There's no problems with those. So in addition, at the time that we decided to start, there had been over 9,000 livers pumped in the United States and transplanted safely with reduced ischemic cholangiopathy, reduced PNF, and early graft dysfunction, all those things. So that's why we thought we could do it in a child. So then we moved on, and you had to look at some of the outcomes data. And as you can see, with machine perfusion, both patient and graft survival was better with machine perfusion. Now, this is a very small number of smaller early adult and teenage type livers. There are no donors in here less than 20 kilograms. And so these were all really pediatric donors, but we could see that in teenage pediatric donors, but we could see that when you did that, that the survival was good and outcomes were really quite acceptable, much better than not taking care of the child at all with a shortage of grafts. So anyway, so machine perfusion is not new. If you go back to 1812, if one could replace the heart with some form of injection and at the same time potentially provide natural or artificial produced arterial support, basically you keep the organ or the patient alive forever. And so that was first talked about in 1812. And then in 1885 was the first machine that was brought out to pump organs. And one of the things that we as surgeons know is that the first Nobel Prize in medicine for a surgeon was received by Alexis Carrel at the turn of the 20th century for the vascular anastomosis. But what you don't know is Alexis Carrel was very much into organ preservation and organ perfusion. And his best friend, Charles Lindbergh, helped him write those books. Now, we don't talk much about Alexis Carrel anymore because of other reasons. But at the turn of the century, Charles Lindbergh was flying across the Atlantic, but he was also funding Alexis Carrel's interest in organ preservation and organ perfusion. So that's it's been around for a long time. It's not a new concept, but it it's taken this long to really be able to use it effectively. And then if you look at liver transplantation specifically, the first liver transplant was attempted in 1963. Tom Stargell, I think we all know the story of Eddie Solis. Question is his name really Eddie or Benny? Says one thing in the op report. Dr. Stargell calls him other things in news conferences. But the bottom line is you can see in 63, that was the first attempt at a human transplant. And then the thing that's also kind of interesting is if you look at this slide and you go to the technical aspects, nothing's changed in 70 years. We sew the vena cava the same way we did then. You know, nothing's changed at all. We don't use any of this bypass stuff anymore, and all of that's all gone. But the technical aspects of the transplant are still very similar to the way that Dr. Stargell attempted it in 1963. So how do we get organs to do transplant? And so on this slide, I tried to outline what kind of organs can we get. Well, if you go back in the history of transplant, Dr. Stargell tried that transplant in 1963. That was a donation after cardiac death. The donor was a child undergoing cardiac surgery at the University of Colorado, was not able to come off the pump. Dr. Stargell convinced the family and the hospital and everyone to let him use that liver and try to put it into a patient that was dying of biliary atresia. So that it was a DCD donor. And if you look at the early phases of transplantation, most all the organs were done DCD. It wasn't until we get into later period of time where we defined brain death, and we just had the 50th anniversary of the brain death rules and things like that, the OPOs and life gift, and none of these things existed at that time point. So donation after brain death was really much newer, and for a period of time was the number one way that everything was done, with basically almost 100% of the organs coming from brain dead donors. But as we know, there's always a shortage. So we have tried to figure out a way to use these donation after cardiac death organs. And there's no brain death here. It's just that this patient has had a traumatic injury. We do not expect meaningful neurologic recovery. So how do we get DCD donors? And there's a couple different ways, which we're going to talk about with perfusion. And we're not going to talk about normothermic regional perfusion. I don't know how the laws are with your hospitals in the state of Arizona, but it's very controversial in the thoracic cavity. I myself work at a common spirit hospital. You are not allowed to do normothermic regional perfusion. It's felt to be very controversial. So we'll talk about a couple things, but we're not going to talk about normothermic regional perfusion at all, although it has a very meaningful place in transplantation at this time point, but we will go on to different things. And the one thing I wanted to point out for you is that, like I talked about in 2016, DCD donation was around 15% of the patients. By 2025, it was 45% of all patients. And now, at this time point, there will be more DCD donors this year than DBD. So you have to get on board. You have to figure out a way to make this work so that you can get organs for your patients. And the DCD the protocol is complex sometimes with all the steps that have to be made, and then when withdrawal can occur, who determines the cardiac circulatory arrest period, how long do you wait, how they transfer, and different things like that. So it's a complex procedure in some ways, a lot more labor intensive than the brain dead donor was for us as physicians going to do the donation procedure. But anyway, it is now a very viable way for us to get more organs. And as I showed in the previous slides, it was not being used in children at all. So we figured that is a place we have to go to try to get more organs. So the way we do it is that we use the TransMedics pump, OCS, and I think the benefit of this pump is we can control arterial and venous flow. And I'll show you some consoles later, look like little iPads, almost, it's basically ECMO, right? So we can control flow. And I think that's very important when we're trying to do kids and also when you're using big organs. Organox doesn't work very well in organs over 1,800 grams of tissue. So we use TransMedics. There's a reservoir, pumps warm, oxygenated perfusate. Here's some of the stuff that's in the perfusate. There's also other stuff they won't tell you about. But you have pulsatile flow in the portal vein and the hepatic artery both. The readout is multiple things. You can look at flow. You can look at the temperature. You can look at lactate production. You can look at bile production. You can biopsy it. If you're into it, the guys across the street from you guys over at Mayo look at bile pH and bile glucose. Those things are all useful in telling you how this liver is functioning and what your chance of ischemic cholangiopathy and things is. So that's the pump we use, is the pump from TransMedics. What could the advantages be? Well, I think the biggest advantage is that you get to test the organ before you ever put it in. Think about it. Otherwise, we took a liver out, perfused it, put it in ice, ran off, took it out of the ice, sewed it in, and you had to hope it was going to work. And we pretty much could predict most of the time, but PNF rates were always low, but 3, 4, 5%, depending on the study. But in general, this, if you look at the TransMedics data, and I get it, it's company data, it's not been published, but PNF is less than 2% in these patients. So you can transplant and use marginal donors. You can use DCD donors. You can have some advantages for your life as well. You can kind of schedule things. We like doing surgery during the day if we can. The Mayo guys have shown, and this will be good for Mr. Nickens back there, but he has to fund people to get you more nurses. The turnover rate of the OR nursing at Mayo is dramatically different in transplant now than it was before, since they operate during the day. And so, many times we know that transition is turmoil, and it costs a gazillion dollars to replace people. So if you can not replace as many people, that's going to be helpful as well. The other thing is when you reperfuse the liver, you take the clamps off and you get the rush of blood back through the liver. You can have hemodynamic instability and things like that, hyperkalemia, different things. With the pump, it's all gone. You just take the clamps off. You don't even have to wait and be cautious and stuff like you do with a cold stored liver. You just take them off and it works right away. I'm going to show you some data that shows that there's reduced coagulopathy. You have improved survival in the short term. We don't know about long term. Length of stay is decreased, as is your reduced amount of, we reduced the amount of blood you use in the operating room. So I think there is real advantage to using these machine perfused organs. So if you look at, this is just one slide of how it looks when you do it. Here's your arterial cannula going into the artery here. The liver's all back-tabled so you can see all these things. And then here's your cannula going into the portal vein. Now, one of the things you have to realize is that this is an adult liver, right? So the portal vein in an adult liver is at least 1 centimeter, right? It's normal diameter of a portal vein is 1 centimeter. And so this, you have to think about this in a 300-gram baby. Portal vein is nowhere close to 1 centimeter, right? So you have your IVC cannula dumping your blood back into the reservoir. There's 5 units of blood underneath in the reservoir. It's recycled. The liver eats up all the lactate like it should. It pumps out bile. And on the side here on our monitor, we can show you exactly how much flow there is in the artery, how much flow there is in the portal vein, how much pressure is taking to do that. And then you'll see some other things. We'll talk about how much flow land we're having to give, bile salts and other things that are pumped into the liver to keep it working. But the bottom line is this thing tells you exactly what you're getting before you put it into the patient. And it works very, very well. So here's one of the counsels. So you can see how much, this is a pediatric case. This is not an adult case. This is one of our kids. But you can see exactly how much flow is through the portal, through the hepatic artery up here. You can see how much flow is through the portal vein. You can see what the SpO2 is. You can see the temperature. Over here, you can see exactly how much gas you're giving, how much flow land, what the bile salt concentration and production and infusion and things are. And so you can get all that. And at the same time point, the technician can control and alter some of these things if you need to. So it's very helpful in contrast to the Organox pump, which you can't control these flows as well. So I think that's one of the advantages of this technique. The other advantage of this technique is it comes with a technician who is basically always an ECMO nurse. Organox comes with a OPO person and someone that's not nearly as sophisticated. So I think that's another reason that this is way more expensive, is you're paying for the people. But I also think it's why you get better results is because you have the people. So I think that's one of the things that's important about the Transmedics. Now, when did Transmedics actually get going? So in 2022, God darn it, did it again. In 2022, Jim Markman did a randomized controlled trial with Transmedics, 300 individuals that ended up being randomized. 153 were on the pump, 147 had the usual ischemic cold storage. And there were 20 different transplant centers that were part of this trial. And what you could see is what they wanted to measure was early allograft dysfunction, as well as what they call liver graft-related severe adverse events. And the data showed that the incidence of early allograft dysfunction and the number of these liver graft-related adverse events were both lower in the pumped livers. And so this is the time when Transmedics was able to gain FDA approval. And so then you're going to see it takes off. And that's here, since Transmedics received FDA approval, the number of organs that are pumped has risen dramatically. And on the UNOS benchmark report that just came out in July, it's now close to 50% of all livers in the United States are pumped. You have some centers like Mayo right next door to you guys pump almost everything. There are some centers don't want to pump anything, whether it's finances or whatever. The reason for the pump is the pump, though, has changed things dramatically with this rapid adoption since the FDA approval occurred in 2022. Ours specifically are adults. Like when we were questioning, can we do this in a child? What did we see happen in our adult population? Well, when we were kind of your basic conservative program, we didn't want to use DCDs and anything like that. But once we finally adopted normothermic machine perfusion, our volume increased by 44%, basically overnight, just because you have so many more organs that you can have access to. And because the population of our donors and the allocation of organs that we are offered has switched to DCD organs. There's way more DCD organs now than was before, and there are fewer DBD. And as our population ages and as the population becomes heavier, the quality of the DBD organs is not as good as it used to be. So you have to have a way to get other organs, and you also have to have a way to make sure that they are going to function. And I'll show you some data on that in just a second. But here's one of ours, the same thing. I just wanted to kind of point out the technical aspects. This is a 16 French cannula. This is a 40 French cannula into these. I want you to notice that nothing up here right now, because I'll show you, we have some very highly technical things I'm going to show you in just a minute. But up here, there's our outflow. And so that's what the liver comes to you on. And then one of the good things about this machine is it can travel on a Learjet. You don't have to worry about size. Some of the other perfusion devices can't travel, except like in a van. So getting an organ from a long way away is not very good. Here's the, oh, that's just the thing. Here's the bile cannula. You don't see any bile in it yet because this is just the beginning. This is a replaced vessel here for the surgeons. The chimney technique is what we use all the time. So anyway, so that's one of the pumped livers. So our volume has grown to 120 adult livers a year. 40% of ours are pumped, which is right around the national average. We're a little bit lower than that now. Wait list times go down. Your length of stay is better. We use less blood. There's many advantages from what the randomized study showed, what we found, and I'm going to show you also what the Mayo group has just published in the last couple of months. But the other thing that has come about with the pump is discard. You can see here that in the past, we would frequently discard livers with over 30% steatosis. That doesn't happen anymore. The other thing with altered liver function and stuff, we used to discard many of those livers. We don't discard them anymore. So the pump has not only made the livers that you're using function better and make it so that you get better outcomes, but now we have more livers we can use. The discard rate has gone way down. So that's the adults. So what are we going to do in the kids? So the last piece of data I'll show you before I show you our stuff is this is the Mayo study with Michelle Nguyen. And you can see that early allograft dysfunction based upon graft type. Now, this slide is a little more complex than Markman's, but here's DBD, right? Normothermic perfusion. DBD with static cold perfusion. DCD, normal thermic perfusion, and DCD, static cold storage. And it's interesting, there was not a difference in this group in their study, but the difference in DCD is dramatic. So your chance of having early allograft dysfunction if you use DCD organs and you pump them versus if you use DCE organs and you just cold store them. The outcomes are dramatically different when using the pump. And then if you look at the rest of their data, the bars stay the same. DBD, normothermic perfused, cold stored, then DCD perfused versus cold stored. And what you'll see is that they used less blood, less FFP, less cryo, less volume and platelets as well. The total volume and then the OR time is a little shorter as well in this study. So I think many of these things, when we're looking at cost of a liver transplant, these things add up. Because in the OR, every unit of blood, I don't know how you guys do it, but we get billed by every minute in the operating room. So every minute that goes by, the bill just keeps rising. And every unit of blood, bill just keeps rising. And as we all know, these transplants are capitated. So you only get X number of dollars. And if you can cut back on some of these things, it's gonna make your CEO a little happier. So your margin is a little better. Maybe they'll take some more contracts and not give you such a hard time about the Medicaid patients. But anyway, and then the other thing is that in this Mayo protocol, Mayo study here, as well as in our own data, which is in press right now, survival at 1 year is better in machine pumped livers. And so, and especially if you're looking at DCD, you have DCD livers surviving at a rate way up here compared to those that are cold stored. So survival is better when the organs are pumped. And in the end, we all have to answer to the SRTR. It's public knowledge, we know. And when you look at those bars, I think a lot of times the public doesn't understand that from 3 bars to 5 bars is only like 2 to 3%. Each bar is basically 1%. So you can look at your data, and if you're a 3-bar program, you're kind of, gosh, I'm a loser. You know, I got 93 or 94% survival. 5 bars is only 95 to 96% survival. So if you can get 2 or 3 more percent up here, all of a sudden changes you to a 5-bar program from a 3-bar program if everything else is equal, right? So anyway, so that's the data that we used to come up with the idea that we wanted to pump pediatric livers. So how do we do it? So here's what we do. In the child, first of all, you cannot put a 16 French cannula up the celiac axis, right? It's just technically not feasible. So what you have to do is you have to procure the aorta when you take out the liver. Your cannula goes in one end of the aorta and you oversew the other end. So you're perfusing the aorta to get flow to your liver. And we've even made a smaller cannula now so we can get to the really small aortas, because you'll see we pumped a 7-kilo liver. And so the other thing is how do you make the portal vein work? Oh no, this side of the slide didn't come up. But anyway, what we do is you could take the iliac veins and sew the donor distal vena cava to your portal vein, and then try to infuse into the iliac was a way to infuse the portal. Even with that, you still can't get a 40 French cannula in there. So we had to make a change on that. And you'll see that this is highly technical right here. We took this small cannula and we put it into the aorta. You can see the aorta is oversewn here. Here's the celiac coming off. And we had to tape this together to get a 40 French cannula to infuse this pediatric portal vein up here, which is only this big. And look, we had an 18 French aortic tubing that we put into the portal vein, and then we had to somehow jerry-rig this 40 French into this 18. So we have tape. It's a very sophisticated technique, let me tell you. So anyway, but that's how we kind of started to get around this. And as we went along, we were able to all of a sudden now find an adapter, just basically some Christmas tree kind of thing, right? Which we put in to this big 40 French portal vein tubing. Then we can put it into our 18 French cannula into the portal vein. And then we have the much smaller cannula for the hepatic artery, which is going into the aorta. And then here's bile. Here you can see this liver's making bile right away. So those are some of the variations we had to figure out how to do, to be able to put these livers on a pump. Now, remember that other liver for the adults, that's 2,000 grams of liver, 1,800 grams of liver, 17, whatever. This right here is 300 grams of liver. And I'll show you what you have to do to be able to pump these really small livers. And this is some of our artwork over here, which is not very good. So then here's our Christmas tree, which we finally figured out on how to put it in. Here's our aorta, flow out here. Now, this right here, very important. Don't tell anybody about this. Look at this nice glove full of water so that the liver can't slosh around in there. The machine is made for an adult, right? So, and when you move, the liver goes sloshing back and forth, and then it pulls your cannula out or kinks something, and then it doesn't work. So we had to figure out a way to stop that liver from moving around. So we got a glove full of water, and now we can hold the liver in place so that it doesn't move while we're going from one place to another. But it's highly technical. It's just like many other things you have to do in the operating room to figure out how to make it work. So anyway, so what have we done? The other thing that we had to change is you have to change the flush. The adult flush doesn't work. You know, the pediatric liver is smaller. Physiologically, it's different. It's not used to the same pressure and things that we do to the adults. So we had to change all that. So we had to cut back on flow into the back table flush. We had to cut down on the amount of pressure and the amount of flow in the liver. The big thing is the gas that they use when we would do it with the pediatric liver. Next thing you know, the pH would be 7.6 or 7.7. And obviously, when the liver is that alkalotic, it's not going to clear lactate. But, you know, its job is to make our pH normal, right? So if we're so alkalotic because of the way the machine is set up, the liver can't work. It's not going to. So we had to figure out a way to get rid of some of this gas and to keep the pH normal. Now, one of the problems we're having is that the company doesn't have really a lot of interest in helping us on the machine because we've done 19. You know, they went 19,000, right? So we're still having to jerry rig this gas and everything. And many times the tech has to literally sit there and check the pH every 15 minutes. And when the pH starts going up, we have to turn the gas off to let the pH come back down so we can keep the liver in its normal physiologic world so it'll clear lactate and make bile and do the things it's supposed to do. So we haven't figured that out yet, but we are trying to change it. Gas flow, like I said. And Flolan, on the adults, you wait until you have vasospasm before you start to Flolan. On the pediatric cases, we make sure they're on Flolan from the absolute get-go, from the moment that we put the liver on the pump. The other thing is that I think is very important is you have to get it out and on the pump quickly. So that's why we use the celiac, the portal vein, and you have to oversew this aorta. You use the hepatic artery cannula for the portal vein. The bile duct is a much smaller, just pediatric feeding tube because you can't put a big tube in it, obviously. And we always want to be done within 2 hours of cross clamp. So that's sometimes, as you guys know, you have to wait for the heart and the lung team first, and then you have to get the liver out, and then you have to backtate the liver, then you have to get it on the pump. And there's also a time where the technician has to prime the pump and everything else. So you're trying to coordinate these things and still get this liver on the pump within 2 hours from cross clamp. There is Transmedics data, again, not published, that for the adults, livers that go on the pump the fastest are the ones that perform the best. So that's where we came up with that idea. So here is one of our little livers right here. The glove, we were able to alter their little pads on the side so that the liver would be able to stay stable and not ruin our tubing and everything else. This is one of the early ones where we still had to tape things together. But anyway, we have come up with some of those modifications so that you can use it. Here you can see these are not big livers. This one's 435 grams. So we have to make sure that everything works for that small liver. This is another one, small liver. You can see we biopsy them sometimes to make sure. But again, this is my hand. So this is a pretty small liver right here, so then to be able to pump and get on that machine. Here's one it's just starting one of the cases. You can see that it reperfuses. Here it is cold beforehand. Here it is as it starts to reperfuse. And it's really kind of neat to watch this, just like when you sew in a liver in a transplant or anything else, you watch it reperfuse. It comes right back to life like it can do. I think it's something, to me, it's so amazing still that you can take an organ out of one person, you store it in ice, put it back in somebody else, and it works. It's amazing that you can do that, But anyway, this thing, so you kind of get an idea of what's going on because it starts working on the pump right away. And then here's another one, same kind of thing. You just see that the whole thing is pulsatile. It's great. You can see exactly what the flow is. You can see what the resistance is. You know what's going in. Pediatric transplantation, whole organs. One of the things people always criticize is the resistance in the organ. It's going to give you HAT, all those stories that are out there. And you can get around all that with this thing. You can see exactly what the flow is going to be. You know exactly what the resistance is going to be. So it's very helpful when you're doing these transplants. And here again, we can monitor the flow, the temperature, the crit, everything in there. We have bile production. We have been checking bile pH and bile glucose. I know that the company says it doesn't matter. I have to tell you, maybe it doesn't matter because I've never seen a bile pH less than 7.8, and I've never seen a glucose that isn't relatively low and or lower end of normal. So it seems to have not helped as much, but we do check it still. Keep the pH down. Usually we'd like to see the lactate less than 2 in these pediatric livers. And if there's any concern, we'll biopsy the liver back at our recipient hospital and get it frozen right there to make sure we don't have necrosis and things of the hepatocytes before we would put it in. And I'll show you when that lactate wasn't normal. We did that with. So we've done 19. When we made the slides, it was 17. We did 2 last weekends. We haven't had enough follow-up to put them in yet, but we've done 19 of these little livers. 16 of them have come from donors less than 35 kilograms. And like I said early on, we use 35 kilograms because that's a child. We don't think that, 60 kilo or 70 kilo 17-year-olds are children. So we specifically have cut our study off at 35 kilos. We've pumped 16 of the 19. 2 have been turned down, unacceptable viability parameters, and 1 just did not look good. Didn't have a reason. We didn't have a number, but the liver just did not look good at all. So anyway, most of the donors were less than 20 kilograms, as you can see here. It's now 12 out of 16. Most of them have been DCD. It's now 11 out of 16 have been DCD. The smallest liver that we've tried is a 7 kilo, and we did not use this liver because the lactate didn't come down. I think this was a mistake. It was early on. We didn't know how to control the pH and the gas flows and things like that. So we ended up discarding that liver. But I think in retrospect, that liver was completely usable. We just didn't know how to, at that point in our experience, we didn't know how to handle it yet. And we've gone and transplanted livers that just a little bit bigger, all the way down to 320 grams. So anyways, here's some of our results. TCH is red. Everything that comes from TCH, as Dr. Glover can tell you, is red. Every slide has to be red from TCH. So here's recipient age. This is our data using donors less than 35 kilos versus the nation. There aren't any others. Less than 1 to 3, 4 to 11. There was just one patient here. Otherwise, the only place that's happening is in our center right now. The same thing with weights, less than 10 kilos, 10 to 20, 20 to 40. And then we have a couple bigger ones. Donor age, same thing. Smaller, younger donors. Looking at their, this recipient weight, I'm sorry, donor weights down here. We're not afraid of the small recipient to use the pump for them, and the donor weights are here. Distance traveled, this has ended any restrictions on distance. We don't worry about, we haven't gone to Puerto Rico yet. We haven't gone to Alaska, but we will when we have the pump. We didn't before, and we had to consider the amount of ischemia time, especially depending on, was it drowning, were the numbers abnormal, was there some evidence of any other issues with the liver. We're always nervous about how long we had to travel, how many hours the liver was going to sit. Now we don't worry about it. We just will. I have no idea how long the liver should be on the pump. Transmedics will tell you that if you put a liver on the pump, you should stay for at least 6 hours. But there is no data published yet on what the sweet spot is on the pump. We've been trying to look at ours, and it almost looks like the best numbers we have are in the 12 to 16 hours after the liver goes on the pump. So we, at this point, usually try to leave the liver on the pump we usually start the case at about 14 hours, hour for anesthesia, hour for a hepatectomy. You're putting the liver in usually at about 16, 17 hours. And we seem to think that's the best. I don't know how many, if you guys have tried to pump it, especially on livers that have fat, lactate will come down, then it rises back up for a while, and then you have to ride it out for a little while before it goes back down. And then it seems like you get the best function when you're out there. So you're going to be out there usually around 15, 16, 17 hours. The longest child we've done is 23 hours. So anyway, I don't know exactly what the best timing is, but we're trying to figure that out as well. And DCD versus DBD, you can see that we'll use either one, and we've used more DCD donors than we have DBD donors in this group. And these are all these small children and these small donors. So it's been great for us to be able to use those. Here's one here. Again, it's about the size of a hand. You can see it over here, pouring out bile. They work immediately. They work very well. Here's our data on outcomes. Here are donors. Okay, the first 14 we used, minus the last 2 last weekend, but they're the same as these. Here are the weights. Again, we only include those that are less than 35. We have done some other teenagers that have weights in the 50, 60 range, 70, even if we have 90 kilo kid, teenager. Distance, we're not worried about distance. We can fly anywhere. DCD or DBD, it doesn't matter. In the DCDs, how long are you safe waiting before the donor expires? Okay, at the beginning, some people say 20 minutes. Then we went to 30 minutes. Then we went to 45 minutes. Now we're at an hour. So I don't know what the time is. And the reason I think this works is you got to remember, go all the way back to one of the slides where I showed that when you get offers from DBD pediatric donors, they frequently have more than 30 to 45 minutes of downtime and CPR in your ER. So why can't we wait 45 minutes or more here? I think you probably can if you do it right. But anyway, so we don't know that. We don't know exactly where you can go yet. But as you can see, we keep trying to push it. This patient right here received NRP because we were in Duke. And of course, every Duke heart has to have NRP. So we had to let them do their NRP thing. So that one had NRP. If you look at traveling, Kevin Wong, he's the junior most faculty member. He gets to fly to all these places. And so it's very good for him. You know, he gets all kinds of frequent flyer miles with American Jet. I don't go on any of those, let me tell you. And then, so here's, again, more outcomes data. These are the weights of these livers that we've transplanted. Time to the pump, remember I said we wanted to be on at 120. We make it most of the time. We didn't make it here. This amount of bile, it's amazing how much a 300 or 400 gram liver, how much bile they will pump out over 12, 14, 15 hours. Hepatic arterial flow. Again, you can get great flows through the hepatic artery. I think it helps you dramatically knowing that when you sew it in, you're not going to have that vasospasm that you sometimes get in these small kids and the difficulty with that artery. And then the portal vein flow. We usually see great portal vein flow in these little livers as well. So they function well in the machine. And the machine, it's very easy to follow all these things to get you. So one of the things that we've learned is, here's our 280 gram liver, which we ended up discarding, I think probably because I'll show you the lactate didn't come down and we didn't understand biopsy and flow rates and everything else at that point. So, but anyway, here's just one of our last ones. You can see the pressure, you know exactly how much pressure there is in the artery, you know exactly how much flow there is, what the infusion is, everything else. So it's really very nice to know what's going on before you put it in. Here's our dot graphs on bile production, which we just showed in a more of a graph or chart before. Hepatic flows versus portal vein flows. So they're really very consistent in these donors and very nice. Here's the lactic acid. Some people believe lactic acid is everything in this. I don't know that it is, but you can see that usually lactic acid falls very quickly and stays down. But here's the little guy that we didn't use, this magenta one or whatever. The lactic acid came up to 3. It wasn't like the lactic acid came up to 7 or 8. It was just 3. But it was one of our first cases. We got nervous, so we didn't use it. We should have biopsied it probably, looked at the flow rate. As long as the hepatic artery flow was good, it was making bile, we probably should have used it. But we just didn't have the confidence at that point. And you can see another one here. The lactic acid starts to come up. And I'll show you, we biopsied this liver. And the biopsy looks great, so we went ahead and used it. Here's some lactic acid data, starting lactic acids, final lactic acid, right? And here's our 3, and we didn't use it because we were nervous. Recipients. So if we go back to the very first slide, where are the kids listed? 0 to 5 years. That's where the majority of the list lives. And so those are the kids you can transplant with this pump. They don't have to sit and wait. They're too small many times for a living donor because there's not enough domain. So you can't many times living donor them, even if you want. And I don't know if the state of Arizona pays for living donation. The state of Texas doesn't pay for living donation in Medicaid patients. So I don't even know if you can pay for it here. But many times it's not an option. So then these are the size of these kids. Operation duration, I don't know if that means anything. I think it's a surrogate for how did the case go, right? If you're in and out quicker. And then pump time. So you can see that we've been kind of all over. We don't know exactly where the sweet spot is, but we're trying to figure out where that is with our own data. Here's an ultrasound in the operating room. You can see that this liver, the parenchyma, looks great, but it has resistance. And so at the end of diastole, we had some reversal of flow because there is a lot of resistance in this liver. By the next morning, it's all gone on the same thing. So I think that the livers heal up a little quicker for you if they've been pumped. And our world is not always perfect. We've had a couple things not go so well. We had a child, and this is a, you know, when we look at failures, sometimes complacency is the worst thing for anything, right? It's the worst. Any successful system, complacency is the worst thing. And this is exactly what happened here. This little girl had to go to IR for a line exchange. She was septic. And 15 minutes before she left, she had an ultrasound. Her hepatic artery was fine. She went down to IR, became hypotensive. She bled into her head, and she had shock and things down there. And she thrombosed her artery. And the problem is we did not send anyone down there to help stay with her to make sure that she was adequately resuscitated quick enough and things like that. So that's the complacency error right there. This little girl, I don't know what happened, to be quite honest. She's syndromic. She has a hepatic artery that came right through the middle of her pancreas. She did not have a vena cava. She had a preduodenal portal vein. She had a situs, partial situs. So we transplanted her, and about a week out, she was doing fine. Then all of a sudden, she got really bad pancreatitis, and she thrombosed that artery. So I don't really know why she got pancreatitis that late. I mean, yeah, I think there was dissection around the pancreas when we did the case. But if we believe the pancreatitis is a vascular insult, almost 2 weeks down the road, how did that happen? I don't know what the cause was. But anyway, she thrombosed that artery. And so we've lost, this child expired. This child is still alive. She will need retransplantation down the road, no question about it, because she does have ischemic cholangiopathy. But those are the bad things that have happened to us. Lessons that we've learned: you have to have a team. Same surgeons have to do a case every single time. You can't have 14 surgeons out there doing it once every 2 years or whatever. You have to have the same people all the time. You have to figure out this pH problem so that the liver can actually work. We have to remember that a pediatric liver is not an adult liver. The physiology is different. We need to make sure that we get this pump straightened out. We biopsy when we need to, so we can see if what the liver looks like, make sure there's no necrosis or anything at that time. And I think you have to get in and out of there quick. I don't think you can be there very long. You need to move along and get things taken care of. And so here's a patient that had a lactate come up. We end up do the biopsy, and you can see the biopsy is fine. There's no problems with the biopsy. So we end up using that liver, and it worked just fine. So I think that was one of the lessons we learned as well, is be very liberal with the biopsy. Uh-oh. What did I do wrong now? Oh, no. Did I mess it up? I'm almost done anyway, so. There you go. Okay, so what do I think the role of normothermic machine perfusion is in pediatrics? I think it is going to give us DCDs. It gives us extended time that we can take care of patients. Gives us times we can get drowning donors taken care of. We can take livers that were otherwise marginal. We can handle travel. We can do all these different things by using machine perfusion, just like you can in the adult. So I think it's very valuable. And here's, I think, our most important statement is that with the adult, all of this added to the unmet need in adult transplants. So there are more organs, so that this climbs. We don't see that in children yet, but I think if you take the DCDs that are out there and you hone down on the pediatric ones, you look at 1,100 organs, you can transplant a number of them, right? And these are all just less than 50. Some of them are not going to be salvageable, families, HIV, HTLV1, whatever the reason is, but there's potential to salvage about 27% of all these organs that are not being used. So if you do that with normothermic machine perfusion, what you're going to find is that we can increase our numbers in each of these years that we analyzed by approximately 50 organs, or 40 to 50 organs a year. And if you move over here and you add in 40 more organs, this unmet need in the pediatric list is declining. And so I think it really is valuable, because there are 200 kids a year that sit on the list and don't get transplanted. We can at least get, with this in a very conservative way, just starting with it, we can take care of at least 50 more of these children every year. So I think that's where the real benefit is. What are we going to do in this future? We don't really know what the size cutoff is. We don't really know what warm ischemia for DCD is yet. Rehabilitation of grafts, should there be different things added? I mean, the other benefit of this is looking at, is there a way to prevent allograft rejection? Is there a way to treat the endothelium with things, with different things that can be done in the pump that aren't being done yet? Maybe not as important in liver as would be like in kidney and heart, where rejection is such a bigger problem, but there's lots of things you could probably do while this liver is on the pump that you can help them with. Hypothermic machine perfusion, I don't know where that sits. I know the Europeans are starting and are kind of in favor of it. Not much in the United States at this time point yet. And so where do we go? I think we need to have a database. We need to be transparent with the numbers. It can't just be held by a company. We need to have standards of care for pediatric DCD. I think, in fact, today or tomorrow, Texas Transplant Society is having a webinar on care of the DCD donor. And we need to have the OPO remember to allocate these organs and not just to give up on a pediatric DCD. So anyway, that's about all I have to say. It takes a whole bunch of us to do this, and I'd be more happy to try to answer any questions if you have any. Yes, ma'am.
So in Michigan, we used to split the like you said, and I was wondering if you had done that, and if you had, are you splitting them on the pump, which can be kind of tricky because like it's a Packard blood cell pump and so it doesn't have clotting factors, or you're doing what we did, which is flushing them and then splitting them in cold.
Yeah, we haven't split one on the pump.
Okay.
Have not done one. So I have to tell you, in so many ways in my mind, I think it would be better to split delivery in situ, take the pediatric left lateral segment and just put it in immediately, put the right side on the pump. Because in most centers, like for us, it's a real challenge to be in 2 hospitals doing 2 cases at one time. So usually the organ will be offered to the child. We give the child preference and we go do the child right away. And then the right side sits in the cold for a while. So I think in some ways for me, I'm much more comfortable with the in situ split. I think it's better. And I would then put the right side on the pump so that there's no pressure, you know, to get to
CDs, and then we put them on the pump to make sure like their biometrics were okay, and then split them and like give like a left to really do it once, but for but okay.
Yeah, I've never done it.
And then for arterial reconstruction, so have any of your small livers have like replaced rates? Because even if you like do like a celiac SMA stack, I don't know if you get the small arterial cannula in SMA.
Yeah, so in the kid we don't do that. The kid arteries are all reconstructed with a Y graft. So we take the iliac and sew it end to end into the SMA on the replaced right, and sew it into the celiac, and then use the common iliac as inflow. Yeah, so every baby that has a reconstruction is a Y graft. We don't do the sandwich or the chimney or any of those things on a child.
And then for donor parameters, so I've been to enough DCDs in kids, and then also just DCDs regularly. Do you have donor parameters? Like, so if I go out for like a transplantix and an adult, like most centers will say like systolic less than 80 for 30 minutes or greater than 50 minutes. But with kids, sometimes with the DCDs, like the procure or the declaring surgeon is, or declaring doctor is a little slow. So sometimes you have like a period of time that they have they're not necessarily flatline, but they're pulseless. And so do you have parameters, or do you stick them all in the pump and see how they perform?
Yeah, we don't. You know, we started out with parameters, especially like in the adults, like you said, 30 minutes with systolic less than 80 or 50 or whatever you want to use, right? I think the reason that so many people had so many different ways of doing it is it probably didn't matter, you know, because, you know, that's how most things in medicine are, but there's 10 different ways to do it. They all work. But on the children, we don't have any parameters. We don't really know what the right thing to do is. The other thing I have to tell you is if you noticed, outside of just a couple, most of those children expire very quickly. I think because of their neck, and I think because of the way, you know, their abdomen and everything competes for respiration, I think these children expire faster than the adults do.
Are you doing any routine biopsies on yours, like either when they go on pump or before you take them off, just to
no, we haven't. We haven't. We do more biopsies in the adults because we use more steatotic livers, but in the children we haven't. There's a couple things we should be doing. One is probably protocol biopsies. The other thing is probably we should have better imaging of flow in the allograft. Like we know how much flow there is on the machine, but we don't check it once we put the liver in. So, you know, there's very sophisticated ultrasound stuff now where we can get much more information. We should be doing that. So those are kinds of things that we're starting to do. You know, the flow probe thing, everybody that's tried it, we all know that all you have to do is change the angle and you get a different reading. You can make it say whatever you want to say. So I don't think that's very valuable. But, you know, some of the very sophisticated ultrasound type things probably would be valuable to see what the flow is.
The last question is, I know this is an NRP talk, but if you get an offer for like a, 50 kilo person where they're doing NRP at the other hospital where like you said, Duke in a couple places, everyone goes on NRP. Do you like reconsider like that offer, like from a like practical standpoint, both for the kidneys and livers, if you know that? for NRP is now showing like basically an NRP liver and kidney is equivalent to a D. It's like ischemic cholangiopathy and graft survival.
Yeah, so no, we don't fight against NRP.
Okay.
And in fact, the data that's not been published yet shows that NRP plus OCS is the best outcome.
Yeah, I know. They showed that at the STS last a couple weeks ago.
Yeah.
By the way,
So I don't know if it's real, but yeah. Yeah. I don't know if it's real or not, but that's what the Mayo guys say it's true too. So I don't know. But anyway, so we don't fight back against NRP at all.
Okay. All right. Thank you.
Yes, sir.
Hey, John, good to see you. Thanks for coming out. Great work that you guys are doing. I have more of I get your thoughts on you see happening over the next year or two. As you know, HRSA is kind of looking at, DCD donors as, it's been widely publicized in the media, potential DCD donors getting wheeled to the OR and then moving and then walking out of the hospital 2 weeks later. We know that kids are, certainly have, are much more resilient. Their neuroplasticity certainly is different than adults who have a severe brain injury. So do you see potential moratoriums? What do you see happening in terms of guardrails? Because I think, certainly HRSA has indicated that they're looking at this to prevent, potentially patients whose brain injury is not as severe as what is initially thought.
Yeah, no, absolutely. I think we have to do a better job of which donors that are really kind of given DCD criteria and those that actually get taken to the operating room versus those that don't. I can tell you for us, we get DCD offers all day long, and there are people that are sedated on the ventilator. There are people that have all their brainstem reflexes. So we don't go on any of those because we don't think that there's any chance they will expire. I think that the OPOs and HRSA and the governing bodies need to come up with a better way of monitoring and regulating this, because I think just letting any individual OPO do what they want, especially with all the pressure that there is on the OPO to perform, because if they don't perform their numbers, they get decertified. So I think with all those things, there has to be better kind of guardrails or rules or whatever, because right now it's kind of a free-for-all. It's almost like if a family says they want to go DCD, the OPO just says, okay, let's go, and next thing you know, this patient's going to the OR. I mean, it's like, and then they can't keep them on the ventilator because they're sedated. If they take the sedation away, the patient wants to pull tubes out and stuff. So I don't know. We try to stay away from all of that sort of things. And I'd also agree with you. It's more difficult in a child. But many of them that we've looked at, I think hopefully our ICU guys are pretty good about saying this patient truly will expire. This is not somebody who has a good chance of recovery. So I don't know. I think it's very difficult. But it's probably going to take some better legislation to really control it. And they're going to have to let up on the OPOs. They can't continue to hammer the OPOs because they have only chances to get more organs, right? Otherwise, they get caught in. So I think that it's going to take more. But I do think there's potential for more stuff, more misery to happen. No question. Yeah.
All right. Well, thanks, everybody.